Welcome to this webinar about the Terminally Ill Adults Bill 2024 to 25. Assisting deaths in today's NHS, and it's mainly about the impact upon GPs. So I'm Dr. Rachel Fisher. I'm a GP working in the West Midlands. And just a big thanks before I start to Drs. Mike Blaber and James Haslam for contributing a lot of materials to this presentation. Mike Blaber is a palliative care consultant, and James Haslam is an anaesthetist. So first thing to say, this is really contentious and this is a deeply emotive issue. We're going to talk about life and death. We're going to talk about suffering. We're going to talk about dignity. We will all have opinions and it's impossible not to. And I would absolutely encourage you to have those opinions, to learn and to keep informing your own unique opinion. Before we talk about these things with colleagues, with family, or with people that we don't know, I would just advise you, please assume that anybody you talk to has seen loved ones die with symptoms, as is often the case with those who campaign for assisted dying. And also just be aware that people on both sides of the argument may be really, really struggling and wrestling with a lot of moral distress and be feeling really conflicted and torn. It's quite normal for you to perhaps be feeling quite anxious and uneasy about some of these issues, and be really wrestling with them. I suspect that's why you're watching this. So um, I want to really encourage us all to take that posture of respect and listen to one another as we talk about these issues. So I'm quoting Tim Farron here as he says, "Neither side has a monopoly on compassion," and I think he's absolutely right. And the more I listen to the debate, the more these three themes just keep coming up that both sides are passionately campaigning for, and those are autonomy, dignity, and relief from suffering. So I want to use that common ground and take that opportunity to talk further as we go through some of these issues, and particularly how it's going to affect or may affect us in primary care. So just to start a bit about me, I am a salaried GP working in the West Midlands. I take a lead in the palliative care in my GP practice. And last year I completed the diploma in palliative care medicine at Cardiff University. So the reason I want to give this presentation is that I want us as GPs to be informed and as informed as and equipped as possible about the possible implications of the assisted dying bill before it's imposed on us. So as GPs, we are such a vital voice in this debate, and I'm really passionate about empowering us to speak up before that policy is complete. I am worried about the effect that the assisted dying bill could have, firstly upon our patients, particularly vulnerable patients. I'm concerned about the impact it could have upon our role as GPs, and I'm also concerned about the psychological and pastoral impact that it could have upon us as doctors as well. So, declaration from me: I am not neutral, and actually, I believe that it's very difficult to be neutral in this debate. I'm affiliated with a group called Our Duty of Care, or ODOC for short. That ODOC is a group of healthcare professionals who are within the arm of Care Not Killing, which is one of the big campaigns against assisted dying. It's non-religious and it's made up of a variety of healthcare professionals. So I've tried my best to be as balanced as possible, but I do believe that the only rational way to safeguard patients is not to legalise assisted dying in the first place. I've looked extensively into the affirming arguments, and I really, really deeply respect those who campaign for assisted dying. However, I have found that a lot of the affirming arguments are based on clinical inaccuracies and quite a lot of misunderstanding. So I can only be authentic and present what I believe to be true. I promise that the information I'm going to present is well researched and it is correct to the best of my knowledge, bearing in mind this is a quickly changing landscape, and I promise to be respectful of all views. So I have two aims. The first is to equip you with relevant knowledge and information so that you can make your own informed decision. I'm not asking you to take the same view as me, but I would encourage you to take a view. It's okay to be conflicted, but please don't be apathetic. Next, I wish to empower you. So, whichever side of the debate we stand, our MPs are relying on us as doctors. We know our patients and we know our profession best. MPs are not well versed in what palliative care is, barriers to it, the difficulties of assessing capacity and coercion. It is up to us to help inform our MPs so that they make the safest laws possible. So I'm going to start with some terminology, and then I'm going to move on to talking about the ethics and some of the main arguments on both sides of the debate. I love palliative care, so of course I'm going to talk to you about that. There's a lot of misunderstandings around palliative care, even amongst GPs. So I'd love to just tell you a bit more about that. And then, really importantly, I want to talk to you about the impacts that it might have upon us as GPs. So, apologies for all the words on this slide. Here are the definitions, and I've put these on there because actually there is a lot of misunderstanding about what assisted dying actually is. So generally, I would refer to assisted dying as assisted suicide because that is what it is. In order for assisted dying to come into place, to become law, there would have to be an amendment to the 1961 Suicide Act. Proponents of assisted suicide tend to use that euphemism assisted dying because it does make it sound a bit more palatable. However, what I'm going to do, since I've talked to a lot of people about this, I do tend to use the words assisted suicide or assisted dying fairly interchangeably. So just for the purposes of this presentation, whichever term I use, I mean the same thing. And what I mean when I say either assisted suicide or assisted dying is assisting another person to intentionally end their life. Now, with the Leadbeater's bill, that would be the self-administration of a lethal ingestion. So, in other words, poison or a lethal overdose of a drug. I just want to draw our attention to what assisted dying or assisted suicide is not. It is not about withholding or withdrawing life-sustaining treatments. Withholding or withdrawing life-sustaining treatments involves not starting or removing the overly burdensome or futile life-supportive interventions with the expectation that a natural death would follow. So, for example, just so we're sure, an example of withholding or withdrawing treatment is if somebody in end-stage kidney failure decided that they wanted to stop dialysis, or if somebody with cancer decided that they didn't want to have surgery or chemotherapy for it. They would die naturally of those illnesses. Again, if a decision was made to turn off a ventilator for a patient who couldn't survive without one, that would be the withdrawing of a life-sustaining treatment. So the difference really is about the intention. Assisted suicide or assisted dying aims to deliberately cause death. Currently in the UK, we widely have the use of withholding or withdrawing life-sustaining treatments, and that is not intended to cause death. But death will naturally follow, and that is expected to happen. The reason I make this point is terminology really matters. So I just wanted to have a look at this. This is the assisted dying. This is the Dignity in Dying website, and this is their definition on one of their main pages. They say assisted dying allows a dying person the choice to control their death if they decide their suffering is unbearable. It is illegal in the UK. So the Dignity in Dying used to be called the Voluntary Euthanasia Society, and you may not be surprised to know that they become much more popular since they changed their name to Dignity in Dying. So I just want to imagine that you've never heard of assisted dying before, and just have a look at Dignity in Dying's definition. You could really be forgiven for not recognizing that assisted dying involves suicide, for not realizing that assisted dying involves the ingestion of poison to bring about death. You could so easily read this definition and think that it is about withdrawing or withholding life-sustaining treatment. Bearing in mind, Dignity in Dying state that 75% of the UK public are in favour of assisted dying. This was a survey done by Dying Well. It was an online survey, and they asked, what do you understand by the term assisted dying? And as you can see on this poll, 43% of people got it right. They realised that it was providing people who have less than 6 months to live with lethal drugs to end their life. That's correct. 42% thought that assisted dying meant giving dying people the right to stop life-prolonging treatment, which of course is legal and widely used in the UK already. 10% of people thought that assisted dying meant hospice-type care, and 5% didn't know at all. So I hope you can see this is really quite concerning that, according to this poll, less than half of the UK public actually know what assisted dying is. So that's what the public thinks. What do physicians think? So the BMA undertook a survey in 2022. So 50% of doctors said they were personally in favour of a change in the law to support assisted dying. However, there was a discrepancy here because only 45% were willing to prescribe the medications to do so, and only 26% were willing to administer. So of these 50% personally in favour, they found that the most supportive of assisted dying were medical students, obs and gynae specialists, anaesthetists, emergency medics. And the most opposed were GPs, geriatricians, oncology, palliative care specialists. So basically, those with the most experience of dying patients were actually the most opposed, which I thought was quite interesting. Let's talk about palliative care specialists. So this is based in Scotland, this survey. But they said that 75% wouldn't participate in the dying process. Only 5% were willing to take responsibility for ensuring that coercion was excluded. 98% thought that it shouldn't be part of mainstream care. 86% felt it would have had a negative impact on palliative care services. 84% said it would negatively affect their own personal or family life. And perhaps most starkly of all, 43% said that they would resign if their organisation undertook assisted dying. So I think this is a voice that we really need to listen to. So what do GPs think? Well, the RCGP did a survey in 2020, and they are redoing this survey now. The survey showed that the largest group opposed the law, so that was 47%, opposed a change in the law, on assisted dying. 40% would support the law provided there was appropriate safeguarding. I just thought it was really interesting to tell you, though, as part of this poll, only 7% of GPs thought that GPs should prescribe lethal drugs. And again, it was 7% thought that GPs should, not that 7% would be personally happy to. So I'd wonder whether that number would be even lower if it was, would you be personally happy to do it? And 35% thought that GPs should not be involved with assisted dying. Since I've written this presentation, actually, the Royal College of GPs have sent out another poll. And I am a little bit concerned about it because it asks what we think the RCGP stance should be, whether it should be in favour, opposed, or taking no stance on the change in the law. It doesn't ask us as GPs whether we would be happy to prescribe lethal drugs, whether we'd be happy to stay with the patient, administer the drug, and then wait for them to die. It doesn't tell us whether we'd be happy to refer on if we conscientiously objected or whether we'd feel complicit. None of those questions are involved. Again, it just asks about our ideology, but not necessarily whether we're practically in favour of this. So let's talk more about assisted dying itself. Let's talk about the debate. Let's get into the nitty-gritty of it. There's so many ways to approach this, and I really struggled to know where to start, really. I think it's always a great place to start with the Beauchamp principles of autonomy, justice, beneficence, and non-maleficence. You can't really go far wrong with using those. Can't go through all the arguments, there are just so many of them. But I thought, let's stick with this common ground. So let's talk about autonomy, let's talk about dignity, and let's talk about relief from suffering, because these are really the arguments that everybody on both sides of the debate are talking about. So let's start with autonomy. And you'll notice as we go that actually separating out autonomy, dignity, and reduction in suffering is not very neat. They really intertwine with each other. So, as much as I can, I'm going to cover one followed by the other. So, the first thing about autonomy really is that w- it is not absolute. One person's autonomy will always affect that of another. So here's one of the dignity and dying campaigns: my life, my death, my choice. It sounds really reasonable, doesn't it? And we love choice. I'd go as far as to say we actually even worship choice and autonomy and the individual in Western society. I think culturally we believe that greater opportunity must equal greater happiness, and that greater choice must equal greater freedom. We don't often test that theory though. We just assume that more choice must be better. But total freedom of choice isn't practical and it isn't realistic. We do need limits. One person's freedom will always affect the other. So, dignity and dying argue that everybody should have a choice and control over their death. And again, that sounds very reasonable. But once you make assisted suicide available, you're not just allowing that choice for the terminally ill to decide to die. You're now actually asking everybody who qualifies for that criteria. You're asking them to make the choice too. In fact, you're forcing them to make a choice. And you're then forcing those people to make a choice to live, in spite the fact that they might feel burdensome on their family, in spite of the fact um, that they might be being coerced, or in spite of the fact that they're just feeling obsolete. So, as long as the law prohibits assisted suicide, anybody who's terminally ill doesn't have to make a choice to keep on living. And then another huge argument here is, can that choice to live or die truly be a free choice while health equalities exist? And we cannot deny the existence of those. There are people who sadly feel very lonely, very obsolete. This is a Guardian article saying 1 in 5 older people have been abused. It's a very, very insidious thing. Abuse and coercion, it may not be easily detected. So I would argue, is it possible for the choice to end one's life to be free? And even in those people who have no coercion, are those people not self-coercing if they feel it is the noble thing to end their life? So I would just question, is it really autonomy? Um, so I think it's really important that we talk about why people actually choose to die. So here's the data from Canada, where assisted dying is legal. Um, most they in Canada they call it MAID, medical assistance in dying. So as you can see, the top spot is people opting for assisted suicide due to loss of ability to engage in meaningful activities. Followed shortly after um, is inadequate control of pain, or actually more likely the concern pain might not be controlled. And we'll talk a bit more about that later. High up on this spot, loss of dignity. So over 50% um, opt for assisted dying because of loss of dignity. Um, and then here we are, perceived burden on the family, friends, or caregivers. So 35%. It's a lot of people. Isolation and loneliness, 17%. Um, so the arguments for assisted dying being for uncontrolled suffering um, is not actually particularly high up on the agenda. I grant you it's number 3 on here, but I would argue it's not just inadequate control of pain, it's concern of it. So I'd love to unpick how much of it is genuine unresolved pain. And here are the results from Oregon. So, 91% sought assisted dying because of loss of autonomy, which went hand in hand with loss of engaging in activities, loss of dignity, being a burden. Here we are, 43%. So this fear of being a burden is very, very real. So autonomy and dignity are so intertwined. So I want to move straight on to talking about that. So what is dignity and who does it belong to? It's really hard to define. I don't have a definition for it. And its meaning seems to be changing. So I keep talking about dignity and dying, but I think it's really important to talk about their name here. And I am concerned about their name. The very name itself seems to be saying that to lack a choice is to lack dignity. And that, to me, is very, very problematic. So, is this campaign saying that those who don't have capacity to qualify for assisted dying um, don't have dignity? Or what about those who would opt for assisted suicide, don't meet the criteria? Does that mean that they lack dignity? And what about those who do meet the criteria and who have possibly even been whose lives have possibly even been defined as unlivable, and yet they want to keep on living? Is that a dignifying thing for those people? I just think these are really important questions to be asking ourselves and our MPs. So um, the coalition of disability activists, advocacy groups, um, formed and made a statement. They opposed the bill and made the statement that the bill reinforces societal biases that view disabled people's lives as less valuable. And, I think this is a really powerful voice that we need to listen to. And this is because of this idea that to have dignity, we must have choice and we must have agency. Um, and then we perhaps lead on to more scary ideas. So this is a quote from Matthew Paris, who's a columnist at the Times. He says, "We simply cannot afford extreme senescence or desperate infirmity for as many individuals as our society is producing. Your time is up will never be in order, but yes, the objectives are right. May one day be the kind of unspoken hint that everybody understands. And that's a good thing." I don't know what your thoughts on that are. I find it very concerning. And again, Tim Leadbeater doesn't seem to be concerned that fear of being a burden is a problem. She considers that a very legitimate reason for dying. And I just wonder, what does that say about our society? So another question about dignity is to ask the really logical question of, is this bill discriminatory? So it only allows the terminally ill, and it only allows those with capacity to opt for assisted dying. So is that discrimination? What about those who have 8 months to live or a year to live? What about those who have several years prognosis? People with motor neuron disease are often cited as people who would want this, and yet they may have several years to live. Um, so is this discrimination to only allow certain very narrow groups? So then what's the alternative? The alternative is that we widen the scope, and then that leads us to the slippery slope argument that is very important and very, very much discussed. So the alternative to only allowing the bill to the terminally ill and the capacitous is that we allow it to those who don't have terminal illness, as the Canadians have done, as the Dutch have done. We allow it to those without physical illness. So Canadian law is thinking about extending MAID to those with just a mental health problem. The Netherlands have already extended assisted suicide to, or in this case, euthanasia, to under ones with parental consent. And the Netherlands and Belgium have already extended their bills to include those who don't have capacity. In Belgium, 6% of deaths are assisted, and a quarter of those deaths occur without patient's explicit request. So we talk about the slippery slope, but actually I would argue that this is a logical cliff, actually. The legalization of assisted suicide will fundamentally cause a culture shift. It will cause a shift potentially in how we view dignity. Previously, perhaps we saw dignity as something intrinsic to every human. It may now be viewed as something extrinsic, those who have agency, those who are young, those who don't feel burdensome. It's a fundamental shift in the role of doctors, whereas before we did no harm, we were not allowed to take life. Now we would be allowed to administer poison. And it would be a fundamental shift in that value of life the sanctity of life, which isn't just a religious idea. Lots of humanists and non-religious people believe in that idea that human life is precious. It may well change that into having that shift that some lives are defined as unlivable. And the question is, are we ready for that? I don't believe it is a slippery slope. I think this could be a Rubicon that we cannot ever go back on. Um, we have to talk about Canada. We always talk about Canada and their slippery slope. I think it's becoming more widely known, but just to kind of hammer home, they legalized MAID in 2016. Initially, it was for grievous and irremediable medical conditions and those with a reasonably foreseeable death. Within 3 years, they dropped the terminally ill category. Within 5 years, they then made it possible for people with disabilities. Within 7 years, they're considering allowing it for those 12 years and older. It's now, by 2023, all palliative care establishments and nursing homes were obliged to provide it. So conscientious objection is becoming incredibly difficult in Canada. And now, of course, they're talking about allowing assisted suicide for those who have mental illnesses alone. This is what's going on in the Netherlands. It was legalized in 2001. Within 5 years, they widened the scope to allow euthanasia for infants under 1. And there's now an ongoing debate about whether it should be given on demand for those over 75 who feel they've lived a completed life. The astute among you will be saying, what about Oregon? And so let's talk about Oregon. So Oregon is often held up as the Holy Grail. Tim Leadbeater's bill is based upon the Oregon law, and Dignity in Dying, I believe, are very much in support of it. Proponents argue that the UK would be immune to that slippery slope that we talked about, as long as we follow Oregon's example. So Oregon legalized assisted dying in 1998. And since then, yeah, they really have been able to hold back that tide for longer than Canada and longer than the Netherlands, although I'd argue it's a pretty low bar there. However, there's a really good article that's worth your read. Please look at the references at the end. It's a 25-year analysis taken looking at all of Oregon's assisted deaths. So first thing that they found was that actually 3/4 of the data just was missing. Assisted deaths are not being reported, not being monitored. Of the data that we do have, given that it's limited, and actually Oregon has the best data in the world, and yet it's very limited. So it shows there's huge variation in how long it takes a patient to die. The shortest death was 3 minutes, the longest was 137 hours. And there has been this increase in people desiring death because of feeling a burden. And now in Oregon, it's over 50% of assisted deaths are due to that reason. And there is a rise in people choosing assisted death because of financial pressure. There's no data about the quality of palliative care provided, or whether any of those people who had assisted deaths had any access to palliative care or not. And there's a big question about whether they received a thorough assessment and whether anybody asked the reason that they actually wanted to die. This is an even more concerning observation from this study. So despite Oregon legalizing assisted suicide only for the terminally ill, actually there have been lots of cases of assisted deaths for non-terminal conditions. Anorexia, it's very contentious at the moment, and that's a bit beyond the scope of this, but it is a very important condition to talk about. Other examples include complications from a fall, hernia, arthritis. These are reasons that have been cited for why people have been allowed assisted deaths. And I've been thinking about why on earth could have happened. How could those people have slipped through the net? And my suspicion is that it's because of a phenomenon called doctor shopping. So it seems clear to me that such examples of assisted deaths must have come about because of poor assessment. So the UK bill and the Oregon bill state that if one doctor is not willing or able to complete a declaration for a patient who wants an assisted death, they must refer to a doctor who is willing and able. So if one doctor feels that the criteria are not met or they conscientiously object, patient is then at liberty to find a different doctor who will. So does that mean then that there is always going to be someone more liberal or more unscrupulous than the next? The reality is that such doctors will probably become quite well known, and so certain patients will seek them out and they will end up performing more and more and more assisted deaths. Let's just circle back round to dignity. We got a little bit sidetracked by the slippery slope because I think it is really relevant. But let's just go back. Who does dignity belong to? At the heart of palliative care lies the assertion all human lives are valuable simply because they're human. Not because they have agency, not because they're young, not because they're useful, but because they're human. Cicely Saunders said, "You matter because you are you, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, also to live until you die." So the UK is the world leader in palliative care. And I fear that we are about to signal to the whole world that we believe that dignity is actually only for those who don't feel burdensome to society, and possibly even that our society might be better off without some people in it. So let's talk now about relieving suffering, which is, of course, what we all want. So nobody doubts that this is the intention on both sides of the debate. It's only natural to consider assisted dying if you've seen somebody suffer before they died, or if you fear suffering yourself. But what's really interesting is that the bill doesn't make any mention of suffering. And believe me, I've checked. There are 38 pages of the bill, and at no point does it mention suffering. There is no requirement, therefore, for the person requesting assisted suicide to be suffering. They only need to be terminally ill and have a clear desire to die. The bill requires doctors to discuss palliative care, but there is no requirement in the current version of the bill for palliative care to be optimised. And clinicians don't have any requirement to consider why a person wishes to die, only that they do wish to die, and that there's a reasonable expectation that they will die within the next 6 months. I think there's quite a wide myth that assisted dying is really easy, that you take a pill and you just pass away peacefully in a couple of minutes. I'm going to take you through a bit of evidence that suggests that that is far from the case. And then I'd like to talk to you about the evidence that actually palliative care really can reduce suffering whilst upholding dignity and autonomy. I'd like to make the case to you that we have the answer, but it's just not well accessed. So let's talk firstly about the actual process of assisted suicide. So Kim Ledbetter's bill will require, in most cases, patients to ingest a lethal dose of drug in order to die. There's absolutely no consensus as to which drug. Oregon uses a lot of barbiturates, but actually these are becoming more difficult to find. And with the best data that we have, which is from Oregon, is about barbiturates. The reality is, though, a patient needs to take about 100 in most cases. They would need to be crushed up into a paste so that the patient can swallow them. It would taste very bitter. Bearing in mind, if you remember the previous slide from Oregon, 75% of their data is missing. So of the patients of those deaths that have been monitored and recorded, 33% of them took over an hour to die. That's a third. And 8% of them took over 6 hours to die. So I think we really need to be careful in this assisted dying debate, not to give the impression that it's easy and it's just simple. And I would argue that actually lots of patients, because of the vomiting and the aspiration and the seizures that may occur after taking these medications, which are documented, I would argue that assisted dying could well cause exactly the kind of traumatic death palliative care could avoid. So Other examples of drugs include DDMA. That's one particular combination that's used a lot. It involves digoxin, diazepam, morphine, and amitriptyline. There's loads of different examples. The reality is, the more drugs that you add in, the more side effects you're going to get, and the less you're going to know about how a patient's going to respond. There is evidence that they cause slower and more symptomatic deaths. So this all comes from this paper by Anna Worthington, Elora Finley, and Claude Redwood. It's really worth a read. So here's what I really want to talk about: palliative care, my favourite topic. Does palliative care relieve suffering? So in the debate, I keep hearing people talk about patients dying despite the best palliative care, despite optimized palliative care, and even in Kim Ledbetter's speech, despite maximum doses of morphine and maximum doses of sedatives, which don't exist. This is a misinformation sadly used to scaremonger. So here are the facts. Pain can be controlled and other symptoms in up to 95% of cases, as long as good palliative care is accessed. I would argue it's more than that, based upon the expert advice of many palliative care consultants, um, who have actually been able to go through all of the examples in Kim Ledbetter's speech and explain how they would have cared for those patients. Um, for those patients that really can't have their symptoms controlled, and I really would argue that this is few if we can really optimize palliative care, there is an option of palliative sedation. We almost never talk about palliative sedation. And actually, the reason we don't use it is because a lot of people are a bit squeamish about it because they worry that it might be seen as assisted dying. So, if we're willing to talk about assisted dying as a society, why aren't we willing to talk about palliative sedation? Basically means when a patient is in that dying phase, giving just large doses of sedative, not to hasten death, but to um, cause them to be sedated enough that they wouldn't be suffering. The problem with palliative care is that it's often accessed late, but the evidence really suggests that as long as it's accessed early, that it really is associated with physical, psychological, and existential relief. What's often not known about palliative care as well is that it really can increase the length of time that you live. I think a lot of doctors and certainly a lot of patients fear that it is an alternative to active treatment and it will shorten your life. And that um, it's an option, you can either choose to live longer with active treatments or you can choose to live better with palliative care. It's not true. Actually, there's this groundbreaking study in 2010, big study of patients with lung cancer. Half of those patients were given active treatments, the standard treatments. Half of those patients were given exactly the same standard treatment, but with palliative care as well. And those patients who received palliative care lived longer. And I'd love to talk to you all day about why that is. Don't really have time, but just have a read. It's reference number 5. Um, and then there was a meta-analysis done about what conditions constitute a good death. There were 11 things noted, simple things like relief of symptoms, good communication, dying in the place that you wanted to die, having good continuity of care with your doctors, having your family present, and lots of other things. And this study said that for most conditions for a good death could be offered to most dying people without costly medical infrastructure or specialized knowledge. So what it's saying is the vast majority of patients can achieve a good death with actually really quite basic palliative care. They don't need hospice, they don't need a specialist palliative care consultant or registrar. They just need us. They need GPs to have a good knowledge of palliative care, and they need society to fund it. They need our government and our health service to be able to set up the time and to prioritise it. In their last year of life as well, patients with an advanced care plan are likely to spend less time in hospital, have a better quality of life, have care aligned to their wishes, and are more likely to die outside of hospital. Doesn't this just sound like dignity to you, having these things? But by very definition, an advanced care plan means giving proactive palliative care, not reactive. So let's talk a bit more about that. The top picture here is what, sadly, most patients see of palliative care. They're given burdensome treatment that may or may not extend their life and is unlikely to give them a good quality of life. And then a crisis happens, there is suffering, and then what happens is everybody gives up on active treatment and says, we're going to do palliative care instead. And then within a few days, often they die. So it's no wonder if this is people's view of palliative care, that people are campaigning for assisted dying. I really don't blame them if this is what they see palliative care as. But what palliative care should be, why don't we offer it earlier? So if we offer palliative care earlier in the disease trajectory, look at this bottom image. Gradually, as that patient gets closer to death, disease-modifying therapy might become less appropriate and more palliative care might be needed. We plan for complications, we plan for symptoms, we relieve symptoms, we find out what their priorities are, and we prevent that crisis. And then when they die, we support their families. If this model were actually able to be enacted, and that would require our government to allow GPs the time to do it, um, if this was the palliative care that patients actually received, I would argue there would not be a need for assisted dying. Like I've said, palliative care is poorly accessed. In high-income countries, bearing in mind 1% of our population is expected to die each year, 8 to 11% of the health budget is spent on that 1%. Now, a lot of that is completely appropriate, completely right and justified. But actually, a lot of that treatment is burdensome, and a lot of that treatment is futile and will just result in reducing quality of life and reducing dignity as well. Up to 215,000 UK residents die each year without access to palliative care, despite the fact that 90%, just under, will have palliative needs. That is astounding. And we need to know this. We need to be aware. Before we legalise assisted dying, we need to be aware of how little palliative care is accessed. Only 29% of decedents were recorded on GP palliative care registers in 2012. I can assure you that the vast majority, that way more than 29% of patients can be expected to die. I would really encourage you to do an after-death audit in your practices, and you'll see that the vast majority of patients who die at your practice could be really quite reasonably predicted. So palliative care is poorly understood by the public, but it's actually really poorly understood by us as well, by healthcare professionals. So resident doctors who care for dying patients on the ward are frequently reporting that they're feeling out of their depth and unsupported by their senior colleagues. And that's because their colleagues are distancing themselves from dying patients and not acknowledging death is a possible outcome of serious illness. I'd like to say that GPs are a bit better. And this study, the 26th reference, is perhaps a bit of an older study. And frankly, it's the only study I can find because it's not being looked at how GPs consider palliative care. Only 15% of patients saw themselves as providers of palliative care. And so many of them wrongly believed that palliative care is just for the last 48 hours of life. And it does make me think back to my time on the wards. I can remember having a very heated debate with one of my consultants who was an excellent doctor, who was asking me to do a really quite painful intervention on a patient who was clearly actively dying. And again, having conversations with doctors who asked me not to prescribe anticipatory medicines, despite the fact that the patient was suffering and dying, because they were afraid that those medicines would hasten that patient's death. I've been accused of trying to kill my patients, even from colleagues as well as as well as patients, when all I wanted to do was give them the symptom relief that they desperately needed. Um, and I just wonder, is all this misunderstanding fueling the polls? Is it the doctors who are not aware of what palliative care is, who are not aware that it provides symptom relief whilst not hastening death and arguably potentially increasing the length of life? Is it these doctors who are in favour of assisted dying because they don't understand palliative care? And, and that's potentially what we saw from the polls before. Those who are more involved with caring for the dying are much more likely to be um, against assisted dying. So what's the solution? Palliative care is effective, but it's poorly accessed. What's going to be our solution? And I would argue that either way, we would need a massive culture shift. So option one is we improve death literacy. And that would result in improvement of palliative care access. It would require palliative care to be delivered by all doctors, not just for hospices who are under-resourced and desperately oversubscribed. It would mean palliative care should be taught at medical schools and embedded into the ethos of what it means to be a doctor. It would mean that the public would be more death literate and more able to talk about advanced care planning amongst themselves and amongst doctors. It would involve doctors being willing to talk about death, willing to acknowledge death as a possible outcome of disease, rather than giving futile treatments. And this would hopefully all result in opportunities for advanced care planning to happen, for palliative care to be proactive rather than reactive, to plan for complications, to avoid complications, and ultimately to improve the last year of patients' lives, and potentially even to prolong lives. The second option is that we give up. We say, okay, well, palliative care is great, but it's not accessed. So let's let people let's assist deaths instead. Which makes me really sad. Um, it is this really our answer to poor palliative care access? Is this really our answer to health inequalities? Lovely. Thank you so much for anyone who's still listening. Thank you so much for bearing with me. I'd like to do more of a deep dive into the bill itself. I'm not going to cover the whole thing. I do suggest that you read a copy of it at some point. You can find it online. It's about 38 pages long. It takes about 10-15 minutes to read. It is worth being prepared and aware of what might be coming our way. Be aware that the Bill Committee are meeting in the House of Commons as we speak, and so amendments are being made. So this presentation is subject to change and will be out of date very, very quickly in this rapidly changing landscape. So assisted dying can be requested by anybody who is terminally ill, who has capacity to make a decision to end their own life, is aged over 18, and has a clear, settled, and informed wish to end their own life, and on the basis that this decision is taken voluntarily and they haven't been coerced or pressured. So a terminal illness is defined later in the bill as somebody reasonably expected to die within 6 months. Capacity, as I'm sure we know, is very complex and can fluctuate. And I wonder as well, can a wish to end one's life be truly informed? And can it be truly unpressured or uncoerced if there are health inequalities at bay? And are we really sure that we're able to identify coercion on the basis that it is often incredibly subtle and insidious? Section 2 defines the terminal illness, and here's paragraph 3. There's not a lot to be said about capacity, really. Just says as long as basically capacity is defined by the Mental Capacity Act 2005. Now, I don't know about you, but I can think of many cases where I've really struggled to be sure whether a patient has capacity or not. And even cases I've referred to psychiatrists who themselves have not been sure or as a team have been conflicted. The bill seems to imply here with this very short sentence that assessing capacity is very simple. Section 4 says that no registered medical practitioner is under any duty to raise the subject. This is being contested already by various voices in the debate, and we'll talk a bit more about conscientious objection later. Clause 5 says a registered medical practitioner who is unwilling or unable to conduct the preliminary discussion must refer them to another registered medical practitioner who the first practitioner believes is willing and able to conduct that discussion. So this is section 7. So this is what would be requested of the coordinating doctor. Now, who is the coordinating doctor? Nobody knows. I think we'd be pretty naive as GPs to think that this is not going to be us, or at least won't be suggested that this should be us. And it's just really interesting. Nobody's asked us. So this is what the requirements are of the coordinating doctor, bearing in mind we have 10-minute appointments. We need to ascertain whether they are terminally ill, whether they have capacity to make this life-ending decision, whether their wish is clear, whether it's settled, and whether it's really informed to end their own life. So to make sure that that wish is really informed, they would presumably have to know the ins and outs of what's likely to happen, the ins and outs of what palliative care is or is not available, and the ins and outs of what assisted dying would involve. They would have had to make that first declaration voluntarily and not been coerced or pressured. So we would have to assess that and ascertain whether we think that is the case. We would then have to refer that person on as soon as practical to another registered medical practitioner who, again, has to be willing to carry out the second assessment, and that person is the independent doctor. There is no requirement, you'll see, to know the patient or have ever met them before. There's no requirement to ascertain why they want to die, only that they wish to die and that they're settled in that decision at that particular moment that you're seeing them. There's no, as far as I can tell on my reading, I might be wrong, but there's no requirement to tell whether this decision is reversible. There's certainly no requirement to find out if the person is suffering. And there's no need to ascertain that palliative care has been optimised. There is a requirement to discuss it later in the bill, but not a requirement to optimise it. Section 8 then goes on. It requires the second assessment by the independent doctor to do a very similar set of things. Again, they don't need to know the patient. They don't need to ask why the patient wants to die. And they don't need to establish whether that patient's actually suffering. So, section 9, this is about the further provision. So the assessing doctor must examine the person, which is good. I think that's a good thing. And they must be able to explain and discuss the diagnosis, the prognosis, any treatment available, any palliative care, hospice or care, symptom management and psychological support available. And we need to explain to them about the nature of the substance that might be provided. Again, this is problematic because we don't really know a lot about the substance. Nothing is licensed and all these drugs are experimental. And then we need to discuss with them their wishes in an event of a complication. Again, we don't know what the complications are. Here's section 10, and this paragraph really concerns me actually. If following the second assessment, the independent doctor refuses to make the statement mentioned in section 8, that's the second doctor's assessment, that's similar to section 7, coordinating doctor, that's potentially us, if requested to do so by the person who made the first declaration, refer that person to a different medical practitioner who, and there's these words again, is able and willing to carry out a further assessment. Now, as far as I can tell reading this, it looks as though if the independent doctor feels that the patient might not meet the criteria for assisted suicide, that they're required to refer that person on to someone else willing and able. So this applies to me, but if the referrer is too scrupulous or conservative, that there is a very easy ability of that patient to keep doctor shopping until someone with few enough scruples is willing to go ahead and sign that second declaration. And this is what I was saying before about how Oregon managed to get to allow assisted deaths for people with non-terminal illnesses. I think this kind of doctor shopping is what allowed people with hernias or anorexia or arthritis to meet the criteria for assisted dying. Um, so now let's talk about the coordinating doctor's role. Um, So the coordinating doctor must remain with the person until the person has self-administered the approved substance and the person has died, or it's determined by the coordinating doctor that the procedure has failed. So like I said, currently we don't know who the coordinating doctor is. Um, I hope it's going to be fairly obvious that this is really impractical for GPs. Um, what if the patient takes um, a long time to die? Um, what if they only manage to take half the medications and then they're symptomatic from it, but they don't actually die? How do we know when to decide that the procedure's failed? How long do we wait? Um, and I'd love to know if there's any support in place for those people waiting with the patients who are dying, both family members but also doctors. Um, So here's section 29. If I read this right, it means that no coroner referral is required. If the same is true in Oregon, that potentially explains why so little of the data following assisted deaths is available. So I worry here about the lack of monitoring. So then, if GPs are called upon to be the coordinating doctor, or even to be involved in any way at all, even if we aren't required to do actually carry out the practicalities of assisting the death with the medication, helping a patient to ingest it and then wait with them until they've died. Even if that isn't required of us, we are still going to be involved. It's very unlikely, unless significant changes are made to the bill, that a GP wouldn't be involved at all. Um, so Australia has a fairly similar bill to us. Um, their doctors have reported that each assisted death requires around 60 hours of professional time. I just want to let that sink in a little bit. Um, I'm sure everyone watching here knows the pressure of a busy GP day. And this RCGP article just really brings that home. 2 in 5 GPs are already considering leaving the profession in the next 5 years due to the extreme pressures. Most GPs report inadequate time to safely assess and treat patients in their usual clinics. Most GPs report inadequate time to build crucial trust-based relationships. So if we throw assisted dying into this, is this really realistic? And our MPs need to know this. We need to be telling our MPs this. And the RCGP needs to be making this clear. So the next thing, what if we're wrong? GPs are really good at uncertainty relative to other clinicians. That's what we do. Um, but the stakes are really high now. So what if we miss coercion? We know coercion is really insidious. And what if we get the prognosis wrong? To be honest, I haven't gone into I haven't um, spent a lot of time looking into the evidence for prognostication because, frankly, I don't need to tell a group of GPs how hard it is to prognosticate. Um, I do a lot more of it than average, I think, because I do a lot of palliative care. I'm wrong all the time. I can point you to all sorts of prognostication guides. And one of the things that I try to teach most on is about predicting um, deaths before they happen, trying to find people in the last year of life. It's a real passion of mine. And yet, I get it wrong all the time. What if we're wrong about capacity? I can think of so many stories where I have been unsure about whether the patients had capacity. Um, and of course, capacity fluctuates. And what if the desire to die isn't fixed? Um, it's commonly quoted by proponents of the bill that suicidality increases um, in the terminally ill, that terminally ill people are taking their lives, and that it is cruel to allow them to do that alone. We should be assisting it. But actually, the data is a lot more nuanced than this. There is an increased rate of suicidality immediately after diagnosis and in the weeks shortly after. But if people are well supported and are helped through that time of adjustment, that suicidality reduces again. And then I don't know if this is going to be asked of GPs, um, but are we ready to give experimental poisons to our patients and wait with them until they die? I just want to read this clip. It's from the article cited in one of the earlier slides about the safety of drugs. Um, this is an account written by the niece of a patient who was involved in her aunt's assisted death. The full cocktail included 2 anti-nausea pills, an anti-seizure pill, and 100 capsules of secobarbital. It all had to be ingested within an hour. My attention turned to the kitchen table, where my husband and sister, wearing latex gloves, frantically scraped the powder from 100 capsules with toothpicks, trying to beat the clock. The mountain of powder we poured into more sugar syrup created a of sludge, so bitter it literally burned my tongue. And my aunt, who could barely swallow water, had to drink all of it in less than 5 minutes to ensure success. When we sat back down at the kitchen table, white powder everywhere, we all had to wonder, who the hell wrote this law? We had been forced to assist in the most bizarre fashion, jumping through seemingly random legal hoops and meeting arbitrary deadlines while my aunt suffered, and finally emptying capsules, making an elixir so vile I cried when I knew she had to drink it. This was death with dignity? I think it's really important we talk about the effect that it's going to have on us, potentially, as clinicians. So, in Canada, they're really struggling to find doctors to actually perform assisted deaths, which is why I would urge you to talk to the RCGP because I think our poll really doesn't capture that. In Canada, a majority of those doctors who have refused to participate in assisted suicide, um, they did that on not based on religious or moral grounds, but because of the fear of repercussions on their mental health. Of those who are involved in assisted deaths, 30 to 50% of them describe a negative psychological impact, and in a fifth, that impact is ongoing. So this is let's talk about conscientious objection because it's really often said this is just for people who want it. Anyone who want to be involved doesn't have to be. Now I've already made the point that patients who don't want assisted deaths actually are forced to make a decision to keep on living. So it does involve everybody, who certainly everybody who's terminally ill. But I think it really involves all doctors as well. Um, I really, firstly though, I really, really do respect Dignity in Dying's position on conscientious objection. I truly believe that they wish to protect doctors who conscientiously object. And I find their statement here heartening. People who do not wish to support assisted dying shouldn't be forced to do so. Sadly, though, I don't actually think it's very realistic. So, Montgomery ruling states that we should be offering all available and appropriate treatment options to patients. Now, of course, that begs the question: is assisted dying treatment, which may have an impact here? But current GMC guidance does not permit us to withhold certain options from patients. Um, and then paragraph 5 that we've already looked at and clause 4 of the bill says that anyone who is unwilling um, to sign a declaration, sign off on the first assessment for a patient, would have to refer to a practitioner who was able and willing to perform an assisted death, or at least to conduct that discussion. So the reality is that there will be some doctors who are willing to do that, and they will probably become known. It probably will become well known that this is the doctor in your area who's willing to do it. Also, for those of us making the referral on to this person, um, or anybody who we deem willing and able, I would certainly feel complicit in doing this. So in the Netherlands, under Dutch law, even if all the criteria are met for assisted dying, no clinician is obliged to get involved with euthanasia or assisted suicide. So in theory, the law protects these doctors. But I just highlighted some of this. The majority of Dutch physicians feel pressure when dealing with a request for euthanasia or physician-assisted suicide. And then I've just screenshotted further down in this study. 15 GPs described a total of 36 cases of EAS, euthanasia assisted suicide request, in which they experienced pressure. And that pressure included emotional blackmail, control and direction from others, um, counter pressure by patients' relatives, time pressure around the referred patients, and even organisational pressure. So this does worry me about whether this would occur in the UK because of culture shifts. And then what about the damage to the doctor-patient relationship? So please keep in mind my slides from before. Bear in mind how poorly understood palliative care is. In almost every case of my patients with palliative care needs, I've had to address their fears palliative care might shorten their lives. My patients already fear palliative care will shorten their lives, and I've personally reassured my patients time and time again that any intervention that might shorten their lives is illegal. Telling them that it is illegal has been one of the most reassuring things I've been able to tell my patients. And I'm terrified I may no longer be able to tell them that. And that the patients who already struggle to understand what palliative care is and what I'm offering are really going to be able to struggle to unpick the really nuanced difference between the withdrawal of life saving treatment, good palliative care, and assisted dying. So I just wanted to list some examples of things that have been said to me. You're starving my dad to death. This was a really well-meaning family who loved their dad. He was dying from end-stage dementia, which is the nice guidelines say we shouldn't be giving enteral feeding to patients with end-stage dementia, and it is a well-known part and parcel of late dementia that reduced oral intake happens. Are you saying dad's too old to get treated? You're just trying to save money. This was the son of a gentleman in his 90s who had gastric cancer. He told me very clearly he didn't want surgery and he didn't want chemotherapy and he wanted palliative care at home. But his son was really struggling with that decision, and his son accused me of being ageist. Just, again, because of that misunderstanding and because it's a really difficult and emotive area. And people naturally want to care for their loved ones and naturally feel very emotional about these decisions, of course. Um, and then a 98-year-old lady said to me one day, please don't give me the lethal injection, as she looked really scared. Um, this was a really intelligent lady who was very clear in her wishes that she didn't want to go to hospital ever again, regardless of what was wrong with her. She was actually quite fit and well. But I told her about the options available to her in the community, and we filled in an advanced care plan. Um, Putting together a very clear um, a very clear statement of her intentions with the aim of empowering her. But she had visited her poorly husband in hospital some years earlier, um, and had seen patients being given injections, and these patients had died. Now, I can only assume that these patients had probably been given vaccine injections and had died because they were poorly and were dying. I mean, I did say to her, if this is something you really believe, you should be telling the police. Um, I've no idea really what was going on in this lady's health beliefs or what she'd misinterpreted or what she'd even seen, whether maybe she had witnessed a crime. But again, I was able to tell this lady that the thing that she feared was illegal. I couldn't tell her that anymore. There's so much more to say. And thank you so much for bearing with me. There are so many arguments about this, but I'm going to make this my last point. Um, and that's about suicide prevention. Now, do excuse me, my little daughter's woken up and has now joined me in this recording. A huge part of our work is suicide prevention. And I just wonder, what might we in the same clinic be referring one patient against their will for a mental health act assessment for suicidality and another to a colleague to aid their suicide? How can we easily distinguish between these groups? Dignity and Dying say dying people are not suicidal. That's what they've written on their website. Um, and yet we know firsthand that depression rates amongst the chronically ill and disabled communities are very high. So how do we distinguish between a mentally unwell, suicidal person and a rational person who wants assisted dying? Um, I just wanted to highlight this image and the confusion it causes. So I've had some quite interesting targeted advertising recently um, because of my Google searches. So this I typed in drugs for assisted dying into Google, and Google was concerned about me. It's safe to say, which is quite reassuring actually. Um, but and it seems to want to prevent my suicide. It just really highlights how confusing this issue is. Are we preventing it or resisting it? Um, this is the Samaritans' um, stance on it. They say every life lost to suicide is a tragedy that impacts entire communities. I couldn't agree more. Um, but sadly, the Samaritans are neutral on the issue of assisted suicide. I've written to them actually. Um, I've got some good friends who are psychiatrists. Um, they they've pointed out to me depressed people aren't eligible for assisted dying under the current bill until they're diagnosed with lung cancer. What happens then? Do they then meet the criteria? Um, Again, we've discussed before. What about those who feel initially hopeless after a terminal diagnosis? Um, what if they're not given time to adjust and not given good care, but encouraged instead that their life is not livable um, and quickly allowed to have assisted dying? Um, so imagine then a patient might be sectioned under the Mental Health Act because of their suicide risk. What if that patient sectioned then develops a terminal illness? Are they then eligible for assisted dying? So there's so much more to say. There's so many more arguments. I could talk about this forever. But thank you so much to anyone who's made it this far. I will end it there. Um, this is definitely not an exhaustive list of points or concerns. This is probably the most important slide, though. What should we do about it? There's been a lot of information that I've given you. How should we respond? So, first of all, I would really encourage you to take a view. You don't have to take my view. It's okay to be conflicted. Please don't be neutral. Please don't be apathetic. Being neutral doesn't protect anybody. It doesn't protect our profession. It doesn't protect our patients. Um, Whatever your ideology, and you may well be in favour of this bill in an ideal world, are you in favour today, in today's NHS, with today's landscape of primary care, with palliative care being as it is, with hospices being underfunded? Are you practically happy with getting involved in being the coordinating doctor? Um, so if you're in favour or you're feeling conflicted, please write to your MPs and try and meet your MPs if you can. They desperately need us to tell them, to inform them, to help them to understand the decisions. They are doing their best, trying to make the right decisions, and we need to help them in this. So if you haven't already written to your MP or met them, please do that. Um, and please do so to safeguard your own well-being, and to consider how we'll mitigate it against any moral distress. Please write to the Royal College of GPs and anybody else who represents you, the BMA as well. If you're against the bill, um, please do the same thing. Inform your MPs, let them know about your concerns and your Royal College. And in addition, if you're against, please consider signing our duty of cares declaration. But I just want to encourage you, please don't be neutral. Please don't be silent. Please speak out on this issue. We need to be informing policy before it's imposed upon us. So thank you so much for listening. Quite a few references. I'm just going to cycle through them quite slowly. Hopefully all of these references would be worth your reading. There is quite a lot to read here, but I would encourage you to read some of the papers that I've quoted here. And thank you again.